We will start, okay? So
Great.
good morning, everyone, and thank you for joining us to our international rounds. It's my great pleasure to introduce today Dr. Will Miranda from the Mayo Clinic, who will speak about a topic that I think is extremely interesting, which is exercise catheterization in adults post-Fontan physiology. So Will, thank you for joining us, and I'm really looking forward to your talk. The floor is yours.
Great. Rafa, thank you so much for the invite, and thank you to the entire Toronto group. It's truly a pleasure to be here. So this morning, we're going to be talking about exercise catheterization in adults post-Fontan, and hopefully I'll be able to convince you that this is a new diagnostic tool in the assessment of these patients in 2023. Now, I have no disclosures, but it would be impossible to give this talk without acknowledging these two individuals. So on the left, you can see Alexander, who really started this journey. He really spearheaded this protocol and without touching a single catheter, but that's typical Alexander. Now on the right-hand side, you can see Charlie, who was our fellow when we started this, and he's really been instrumental in the learning curve and actually analyzing the data that we gather along the way. So my thank you to you both. Now moving to the learning objectives. So we're going to review the basic principles of exercise physiology. We're going to talk about applications of exercise catheterization post-Fontan. And finally, we're going to talk about some non-invasive markers of adverse hemodynamics that we might use in clinical practice. Now, I think it would be impossible to talk about pathology without talking about normal exercise physiology first. And throughout the talk, we're going to be talking about this. So this is the setup that we have in our cath lab. Excuse me. So you can see the VO2 machine on the right, the fluoro camera here, and this is our bike. So from now on, we're going to be talking about exercise supine cycling, so exercise bike. And what do we know about the cardiovascular responses to supine exercise? Now you can see as we pedal more and more, heart rate continues to go up. And stroke volume initially goes up, but then plateaus as we start limiting LV preload as the heart rate goes up. As we integrate these three graphs, I think it's pretty clear that those two factors contribute to cardiac output augmentation differently. And you can see the heart rate actually contributes more than stroke volume augmentation as we increase cardiac output with exercise. Now, not only they differ in normal individuals, but they also differ when we look at normals and pathology. And this is data from Greg Lewis at Harvard. I'm a big fan of his work. And you can see here that he looked at patients with HFrEF and HFpEF and compared to normal individuals. And as we look at heart rate response and stroke volume response to exercise in pathology in heart failure, you can conclude that both are blunted. So stroke volume response and heart rate response are blunted compared to normal individuals when heart failure patients exercise. And I think this is a critical concept, and we'll come back to that as we think about our Fontan patients. Now, we established that cardiac output equals stroke volume times heart rate. We've known this for quite some time. But this is different than what we think about cardiac output calculation in the cath lab, because when we're in the cath lab, we think about using the Fick principle. So let's go to the Fick formula. And here's the classic Fick formula. We all know it. So it's cardiac output equaling VO2 divided by AVO2 difference. So it's the arterial O2 content minus the venous O2 content. And as we use this formula, we can then conclude that cardiac output is directly proportional to VO2. And this really gets into this question of what determines peak VO2. So what determines VO2 at peak exercise? And let's go back to our formula and then break it down further. So using this, we can conclude that VO2 is also directly related to stroke volume and heart rate response during exercise. Now, this is intuitive, but I think the thing that is less intuitive and the thing that sometimes we don't talk about is what's in the denominator, the AVO2 difference. Now let's rearrange this further, because as we do, we can also conclude that VO2 is directly proportional to AVO2 difference. Now let's make this simple. We're going to forget the hemoglobin part. We're going to forget the dissolved O2 part. And as we do so, you can conclude that AVO2 difference is basically reflecting the difference in arterial O2 saturation and in PA, or venous O2 saturation, if you prefer. Now let's think about what happens during exercise. So as we exercise, arterial O2 saturation shouldn't really change. So in order for one to augment AVO2 difference, with exercise, the only way to do that is by really dropping your PaO2 saturation, or your venous O2 saturation if you prefer. And if we go back to Bromwald's data in the very beginning of this, he showed that normal individuals actually drop their venous or PaO2 saturation less than 30. And the reason for that is because the skeletal muscles are using up, so extracting all this O2 in the periphery in order to support the body during the demands of exercise. So this is a critical concept. And again, we're going to come back to that in the future slides. But this is complicated. We just went through a bunch of formulas, and why care so much about these different determinants of peak VO2 post-Fontan? And the reason is the following. And again, this is data from Diller looking at a large cohort of Fontan patients. And when he looked at this, he concluded that normal peak VO2 is almost zero in patients post-Fontan. So in other words, exercise intolerance is almost universal in patients post-Fontan. And as you think about the complex single ventricle physiology, I think it's mandatory that we really break it down into all these different factors and different determinants, because really this is the critical step as we try to improve their exercise capacity and perhaps come up with some therapeutic interventions. Now, we've been talking about flow all along, but what about pressures? Because this is what we talk about the most actually in clinical practice. So what is the relationship between flow and pressures? And pressure is proportional to flow. This is one of the classic rules of hydraulics. It's important to think about compliance too, because if compliance is good, changes in flow are translated into very minor changes in pressure. However, if compliance is bad, minor changes in flow result in larger changes in pressure. And this is very topical when we think about heart failure, and is very topical when we think about Fontan. So keep that in mind. Now, as we summarize our concepts for exercise physiology, cardiac output significantly increases during exercise, and this is largely related to changes in heart rate and to a minor degree related to increases in stroke volume. Now, we established that VO2 and cardiac output are directly related, and as we apply our Fick principle, we can conclude that VO2 is also directly related to AVO2 difference. So in other words, the peripheral extraction of O2 in the skeletal muscle. Now, lastly, remember pressure is proportional to flow, but compliance is critical because compliance determines the delta pressure for a given change in flow. Now, I think before we jump into the cases, why don't we just recap what is known, or perhaps how little we know about invasive exercise hemodynamics post-Fontan. And surprisingly, there's not a whole lot out there. But amazingly, actually, when we go back to the literature, the first report goes back to 1982. And this is work from Jim Locke before he actually left to Boston. He was still in Minnesota. And he looked at the exercise response in 5 AP Fontan patients. Now, he concluded that venous pressure goes up and that low cardiac output was present at rest and during exercise. And this is not surprising, but perhaps the surprising part was that ventricular filling pressures remain normal with exercise. Now, it should be noted that this was a cohort of adolescent patients, so perhaps not reflective of what we see in clinical practice. But as you look at this, you think, well, boy, maybe things are not as abnormal as we think. Now, but as we fast forward and we go to Alexander's first paper on this, and really this is what started this whole kind of journey. When we looked at our own data, actually things were quite abnormal. So here we're looking at changes in PA pressure, so changes in Fontan pressure, indexed to pressure changes in flow. And as we do that, and we look at the slope, so again, the compliance of the system, actually the compliance was abnormal in a large number of patients. And not only that, the slope actually was associated with then organ dysfunction. So this was more than an academic endeavor. Actually, this was associated with abnormalities in clinical variables. So this is really important. And again, this is really what started this whole journey of invasive exercise physiology in our practice. Now, enough about physiology before I put you guys to sleep. I think let's go over some real cases because they, I think, illustrate what we've been doing here. And let's start with Fontan failure. I mean, this is the thing that we all fear and all struggle with in clinical practice. So this is a 27-year-old male with hypoplastic left heart syndrome. And then he was referred to us because of exercise intolerance and refractory ascites. And by the time he got to Mayo, he was functional class 3. His history was complex and it was actually punctuated by all these Fontan-related comorbidities. recurrent atrial arrhythmias, liver disease, worsening cyanosis, worsening ventricular function, and also some degree of AV valve regurgitation. So very typical in a patient with Fontan failure. Now let's focus on his liver disease. So the ultrasound showed cirrhotic appearance. The spleen was actually quite large, measuring more than 17 centimeters. And he actually had biopsy-proven cirrhosis. Despite that, he only had small varices on EGD, but the main issue had been the need for multiple paracentesis. And this was despite escalating doses of diuretics, as you can see here. Now moving to his labs, his platelet count was mildly reduced. His creatinine was normal. The bili was also mildly increased, but the albumin was normal. But what catches your attention here is this marked elevation in BNP. Now, not surprisingly, when we put him on the treadmill, he did poorly. He only achieved 29% of predicted. He had a blunted blood pressure response, and the heart rate went up to 127. And he also had worsening the saturation at peak exercise. This is the echo here, and his pictures are challenging, but you can clearly appreciate on the left-hand side that the ventricular function was decreased. And when we colored his AV valve, you can see that there's some degree of regurgitation, and this was called moderate. Prior to coming here, he had a CT, so there was no evidence of Fontan obstruction, as you can see on the left, and there was no evidence of coarctation, as you can see on the right. So somewhat reassuring findings on the CT. And as commonly performed, he also had a cardiac catheterization. And this is a typical scenario. So a patient that is actually quite sick, but very unimpressing resting numbers. So you can see here the Fontan pressure was 12. The wedge was between 8 and 10 with a cardiac index of 2.2 and a normal PVRI. Again, Fontan failure with very unimpressive invasive numbers. And as part of his evaluation here, repeat cath was ordered. And here you can see his resting numbers, again, very similar to what was reported before. So a Fontan pressure of 13, a wedge of 9, a PVRI of 1.3, and perhaps the only difference was the higher cardiac index, as you can see here, 3.6, and we can argue that this is indeed a marker of bad prognosis. Now, but here's when things change, and you can see his resting data here. So complete normal Fontan and wedge pressure. But as we exercise, his pressures really went up substantially. And you can see here, this is both for the wedge and the SVC. So a dramatic increase in Fontan and filling pressures at peak exercise. And when we actually looked at the numbers, you can appreciate this. So his wedge went from 9 to 25. So a significant increase in filling pressures. And as we looked at this, we actually felt that he had severe diastolic dysfunction. And I think actually this explains a lot of his symptoms and his exercise limitation. Now, we've known about this issue with diastolic heart failure and systolic heart failure in patients with single ventricle circulation from the very beginning. Actually, Fontan actually pointed that out himself, that it's critical for this very brittle circulation to have complete normal systolic and diastolic function of the single ventricle. And along the way, we've actually worked a lot on this, and this is a very nice review that was recently published. And despite us knowing about this predisposition and worrying about this predisposition, actually making this diagnosis on clinical grounds is very difficult. And we actually try to phenotype patients invasively and correlate their symptoms to the invasive hemodynamics. And you can see here that this was actually, it wasn't very productive. So when we look at filling pressures, the filling pressures were pretty normal across the board. Again, reinforcing that resting invasive hemodynamics do not match the clinical picture. And this is really what prompted this. So this study was recently published, and we looked at the exercise-induced changes in wedge in Fontan patients compared to heart failure and non-cardiac dyspnea. And the idea was to do what we've been doing for biventricular circulation for quite some time, to increase flow and see what happens to wedge pressure with that. And this is what we saw. So you can see here at rest, although the Fontan pressures were higher than in non-cardiac dyspnea, NCD, actually the numbers were pretty normal. And as we put the feet up, so again, this would be analogous to a fluid challenge, actually there was no difference between the Fontan and the normal individuals. However, with exercise, things really changed. And as you can see here, in Fontan pressures, the numbers or the pressures were significantly higher than in patients with non-cardiac dyspnea, really reinforcing the role of exercise. Now, I would also call your attention to the fact that throughout the entire process, the filling pressures in Fontan's were lower than in HFpEF, and I think really speaks for the need for new cutoffs for this particular population. And I think the issue with the filling pressures becomes even more clear when we index changes in wedge by changes in flow. This is the so-called wedge to flow slope, and this reflects compliance of the system. And as we look at this slope, so you can actually argue that the slope in the Fontans was steeper than in HFpEF, and I think this really clinches the concept that compliance of the single ventricle is abnormal in Fontan pressures, and I think speaks for the importance of us augmenting flow in these patients to unmask what is underneath. And this gets us to the first take-home point regarding invasive exercise hemodynamics in Fontans, that it can really be used to diagnose occult diastolic dysfunction as we improve or increase flow and unmask underlying non-compliance. Now let's go back to his numbers because there's more to the story. Because when we look at the cardiac output response, actually his cardiac output fell with exercise. He went down by almost a liter, and this is very abnormal. So the diagnosis was actually severe diastolic dysfunction and markedly abnormal cardiac output reserve. And this led to this subsequent study, which was trying to mimic what Greg Lewis has done in acquired heart disease and look at these different determinants of exercise VO2. And as you focus on the left panel, you can see that peak VO2 was lower in Fontans than HFpEF and lower than the normal individuals. I mean, this is not surprising. Now, when we look at the delta heart rate change or the heart rate response, we can actually appreciate that there wasn't much of a difference between Fontan and HFpEF. I think underscoring that actually chronotropic incompetence is prevalent in Fontans and plays a role in determining their peak exercise VO2. And finally, when we looked at delta stroke volume, so the increase in stroke volume with exercise, you can also see that Fontan and HFpEF patients were similar. Excuse me. But I think it's important for us to remember that one way Fontan pressures keep or increase their stroke volume with exercise is by increasing right to left shunt. And actually, when we look at delta change in pulmonary flow or effective flow, if you will, actually in Fontans, this was much lower. Again, suggesting that stroke volume response to exercise is abnormal, and this is even in the setting of increased right to left shunt. So again, I think we're establishing here that there are a lot of similarities between Fontan and HFpEF. Now, the clinical picture, of course, was quite abnormal, and the hemodynamics were quite abnormal. So I think we all deemed that this patient needed a transplantation, and he underwent successful heart and liver transplant, excuse me, and is actually doing quite well. Now, let's switch gears here. We're still going to talk about exercise intolerance, but we're going to talk about a different phenomenon now. Excuse me. So this is a different patient. This is a 29-year-old female with PAIVS. She underwent a central shunt in the neonatal period. Excuse me. Then this was followed by a bidirectional gland and finally a fenestrated lateral tunnel Fontan. And at age 12, she underwent percutaneous closure of her fenestration and also LPA stenting. And she was referred back to Mayo because of worsening fatigue and dyspnea, to the point that she came to us, she was functional class 3. And because of this worsening, also the question of need for transplant was posed. Now, in terms of her liver disease, she had biopsy-proven stage 3 fibrosis, but she had no varices. And in terms of her cardiac medication, she wasn't on much. She was on a baby aspirin and a small dose of Lasix. Labs-wise, her platelet count was 149, so borderline reduced. Creatinine was normal, and her BNP was mildly elevated at 329. Now, but when we put her on the treadmill, actually, she didn't do that bad. She achieved 62% of predicted, and you can argue this is actually expected for a Fontan, and she really didn't desaturate much. She also underwent an MRI prior to coming here, which showed a normal LVEF. The LV stroke volume was 78. There was no SVC obstruction, and the Fontan pathway was widely patent. However, it was noted that the LPA was on the smaller side, so measuring 11 millimeters, but there wasn't much of a difference in terms of pulmonary flow between the two lungs. And importantly, there were no AP collaterals. This is her outside cath data. You can see she's on the smaller side from a BMI standpoint. Her LPA and RPA pressures were mildly elevated, and so was the wedge, 13. But the cardiac index was high, 3.9, with a normal PVRI. And this is the picture from the prior cardiac catheterization. Again, it confirms that the Fontan pathway is widely patent and the LPA is small. On the echo done here, you can see that the LV function is preserved, and so is function of the AV valve. So unimpressive findings. And then when we sampled the mitral inflow, this was also unimpressive. You can see that the E velocity was nice and low, so a fairly benign mitral inflow in this highly symptomatic patient. And because of all these discrepancies, a highly symptomatic patient with preserved ventricular function, underwhelming mitral inflow, and actually a fairly preserved CPET result, we actually decided to repeat our cardiac catheterization, but this time with exercise. And here you can see the resting values. So her Fontan pressure was high normal, 14, with a normal wedge, but the PVRI was high, was 3.0, and the cardiac index was low. But this was a surprise, and this is what we saw during exercise. Again, compare this to the prior patient. You can see the pressures were nice and normal at rest, but they remain nice and normal with exercise. So this was a marked difference compared to patient number 1, who was also quite limited. And when we look at the numbers, this becomes even more clear. So the wedge was 9 and it went up to 15. So however cutoff we want to apply to this is a complete normal wedge with exercise. But interestingly, her PA set with exercise was actually quite a bit higher, was actually 51%, very unusual. And as we punch into the calculations, you actually get a cardiac output response that is supranormal. So again, normal wedge pressure, a high saturation in the PA at exercise, and also an abnormal, supranormal cardiac output response despite a maximal study. And the difference becomes even more clear when we compare patients 1 and 2. Again, high wedge for the first, normal wedge for the second, high PA for the second, PA saturation for the second, with a normal PA saturation for the first, and a complete different cardiac output response. So again, as we put this all together, a normal wedge and a high PA saturation at peak exercise for patient number 2, we actually diagnose her with peripheral impairment to exercise. And what is peripheral impairment to exercise? I think this comes down to this balance between the skeletal muscle and the heart at peak exercise. And we know that in order for one to perform to his or hers max ability, these two systems, they need to work together. And it will be very, I think, intuitive to blame the heart and the lungs in a patient with heart failure, but things are much more complicated. And actually, they heavily rely on skeletal muscle function, and in fact, the mitochondrial function in skeletal muscle. So as we go back to our formulas here, I think, again, we established that VO2 is proportional stroke volume and heart rate response. And again, going back to Greg Lewis data, I think we can establish here that both heart rate response and stroke volume response are abnormal. So those two factors are abnormal in heart failure compared to normal individuals. But what about the third component of this formula? Again, the AVO2 difference. Is it abnormal in heart failure? And Greg Lewis showed that it is. Again, as we compare normals to HFrEF and HFpEF, you can actually see that the AVO2 difference at peak exercise, so again, the peripheral extraction of O2 during exercise by the skeletal muscle is abnormal, suggesting that patients with heart failure, not only they have central limitation, they also have peripheral impairment when they exercise. And this is a bit counterintuitive. And lo and behold, when we look at our Fontan data, actually this response was also abnormal. So again, this is data on the exercise venous O2 content with exercise, and you would expect that to be below 5 at max exercise. And in Fontan's, actually this was above that. Not only was above that, actually was similar to data from HFpEF, again, supporting that patients with Fontan also have peripheral impairment to exercise, that this is not just the heart. And perhaps this is the invasive correlate to what we've been talking about now for quite some time about the importance of skeletal muscle function in patients post-Fontan. And again, this is one of the studies from Rachel Cordina, who's done great work in this, but I think this might be one way of diagnosing peripheral impairment to exercise in the cath lab. Again, the invasive correlate of what we have shown non-invasively. And I think I really like this study because this study really emphasized the importance of us doing a holistic approach to exercise intolerance. And again, this is a different study from Greg Lewis looking at the different factors affecting exercise tolerance. And as we think about exercise intolerance and biventricular circulation, we have to think about all these factors, starting with the lung up top, talking about, of course, the heart, but also thinking about the muscle, because skeletal muscle function is equally important for peak exercise performance. Now let's go back to our case here. So again, I think we established that the main player here was peripheral impairment to exercise, and because of that, we gave her an exercise prescription. Now her PVRI was also abnormal, so we started her on sildenafil, and with those two changes, she experienced a marked improvement in functional capacity. In fact, she's pretty close to class 1, and she feels so well that she actually changed jobs, and she's doing a much more demanding job now and is able to tolerate that very well. So of course, a very nice response to therapeutic interventions, and because of that, the transplant evaluation was put on hold. So that takes us to the second take-home point in terms of invasive exercise physiology post-Fontan. And I think we have to remember or resist the temptation to think about the heart. So it's not all about the heart, and I think it's important that we think about the skeletal muscles in this complex physiology as well. Now, finally, let's talk about a third component of Fontan failure, which is liver disease. This is a 23-year-old female with a double right ventricle. She underwent an atrial septostomy in the neonatal period. This was followed by a Glenn and PA bending, and finally she had her Fontan completion at age 3 when she received an extracardiac Fontan, so it was a 20mm homograft, PA debanding, and tricuspid valve repair. Now she did fairly well over the years. She had this mild chronic dyspnea, but actually was quite stable, and it was functional class 2. And she was referred back to Mayo to reestablish care after becoming an adult. Now she did have some liver disease, and you can see her stiffness on MRE, so 3 kilopascal, but the spleen was actually pretty small, so 11 centimeters. And from a cardiac standpoint, she was only on aspirin for a possible thrombus inside the PA stump on a prior MRI. So again, doing fairly well with a small number of medications. Now, but her testing was actually quite different than the clinical picture. You can see here her platelet count was significantly reduced at 84. Now, her creatinine was normal, and the rest of the liver testing was also normal, but she had a much lower BNP compared to the prior 2 patients, so 187. And on the treadmill, again, kind of an average performance, achieving 58% of predicted, but she did desaturate a little bit at peak exercise, again, coming down to 88%. This is her prior cath data, and this was done 2 years prior to coming here. You can see the IVC was 6 with an LPA and RPA pressure of 5. And their conclusion was, despite the presence of a calcified homograft, there wasn't much for Fontan obstruction from a hemodynamic standpoint. And I think we would agree with that. Now here's her echo at Mayo. You can see fairly preserved ventricular function with an AV valve that is actually doing quite well. And as we try to interrogate the conduit on the left, we couldn't really see much. There was a lot of acoustic shadowing. But when we Dopplered it, we got this peculiar signal, as you can see it on the right. There was actually this continuous flow even during expiration. I think that raised some concerns regarding the patency and the status of her Fontan conduit. And that led to an MRI, which calculated her overall EF 33%. She had bilateral SVCs that were widely patent, but they did call attention to this mild narrowing of the Fontan pathway, measuring 10 by 15. And because of her liver disease and the MRI findings and some of the echo findings, she was sent back to the cath lab for assessment of Fontan obstruction. And here we can see her resting data. Actually, the gradient that we obtained at rest was a bit higher than before. So an IVC of 13 with an SVC of 10 and an RPA of 10. The wedge was nice and normal, and the cardiac index was on the higher side at 3.2, yielding a PVRI of 1.7. But this is what happened with exercise. So that IVC to SVC gradient, this is simultaneous gradient, went from 3 to 8. So a marked increase in transconduit gradients as we augmented flow during exercise. And from a number standpoint, you can see this was translated into a significant increase in IVC pressures up to 21, despite nice and normal RPA and wedge pressures with exercise. And in fact, when we calculated her cardiac output response, that was abnormal, only 62%. And you can argue this might be related to decreased preload to the systemic ventricle in the setting of an obstructed conduit. And here you can see her angiography. So on the left, you can see the conduit is indeed calcified. And then as we actually do the angio, you can see that there's this diffuse narrowing of the conduit. And actually you can appreciate there's a collateral coming down to the pulmonary veins as the IVC tries to overcome this narrowed pathway. And during the study, she also had a liver biopsy, which showed stage 3 fibrosis. So because of her liver disease, and then because of the status of the conduit and her thrombocytopenia, we went ahead with stenting. And here you can see on the right-hand side, her post-stenting images. So you can see the pathway went from 10 to 22 millimeters, so a very nice response. And we saw this in a couple patients, so we start measuring gradients IVC pressures with exercise routinely. And as we put our data together, here's the result. So you can see the grade here. So these are patients that had 0 gradient at rest. So if you had no gradient at rest, as you exercise, you still had no obstruction. Now, if you had a small gradient, 1 to 2, or if you have a larger gradient, 3 or more, with exercise, the pressures really increased for a large number of patients. And in fact, you can see the patient with the dark circle there, that in one individual, actually the transconduit gradient went all the way up to 20. So again, significant elevation in transconduit gradients with exercise. And as we correlated minimal Fontan diameter to actually transconduit gradient, this is what we saw, that not surprisingly, those were inversely related. So the smaller the conduit, the more pressure you had with exercise. And then when we applied a cutoff that had been proposed for a small conduit late after Fontan palliation, 16 millimeters, and we look at what happens with exercise in patients with smaller conduits, most of them actually had pretty high gradients. And I think really this really changed the way we look at the size now. And whenever we see a small gradient by MRI or by echo, we really look for and ensure that there's no hemodynamically significant obstruction during exercise. I think this gets us to the third and final take-home point for the invasive exercise Fontan hemodynamics, that it can unmask Fontan obstruction. Perhaps it truly reflects the hemodynamic burden of the Fontan pathway as one exercises. Now, I think we also have to acknowledge that we can't cath everybody, and also that exercise invasive hemodynamics, they're not easy to do. They're time consuming, they require resources, they require expertise. So I think we really have to come up with a way of predicting these exercise hemodynamics non-invasively so they can really apply to every patient seen in the outpatient setting or every patient seen in clinic. And I think as we started doing this, I started to come up with this checklist or trying to predict what we would see at the time of the cardiac catheterization based on the pre-cath data. And I think we can start with the echo, as we do in every patient with a biventricular circulation. And I think there is some value. I think the mitral inflow is sometimes helpful. So if you see that small E wave, so an E velocity that is less than 6, I think that's quite reassuring and typically suggests that the filling pressures to the ventricle are nice and normal. But the Achilles heel here is that we're not very good at estimating Fontan pressures. And I think that's really the limiting factor of non-invasive hemodynamic assessment in Fontans. But I think if the echo is not very helpful, there are some other things that are. And I think we have to look at a broader picture here. And I think that means looking at spleen size, liver fibrosis score, NT-proBNP, and then VO2 on CPAT. So let's go through those one by one. So let's start with the spleen size, because I think this perhaps is a little bit now not very intuitive for a cardiologist. And we know that as fibrosis progresses or cirrhosis progresses, then there's an increase in portal pressure, and that gets reflected to the esophagus, but also gets reflected into the liver, the spleen size. And when we look at our spleen size by abdominal imaging and compared to exercise wedge, you can see that both were correlated. However, this was only a weak correlation. But when we look at IVC pressures during exercise, we can see that actually the correlation was better. And I think this introduces this idea that perhaps the spleen size might work as a barometer for Fontan pressures, either at rest or with exercise. So I think this would be analogous to what we do with LA size in diastolic function assessment and biventricular circulation. So again, something simple that is typically reported on the abdominal imaging that actually might be clinically relevant as we think about underlying hemodynamics. Now, what about the liver? And I think the liver colleagues have been using these liver fibrosis scores for quite some time, and they're serologic markers of fibrosis. They're widely used in other hepatic disorders, particularly in viral hepatitis, but more recently they've been shown to correlate with biopsy results in Fontan-associated liver disease. And here, excuse me, you can see two of these scores. So the first one is the APRI, which incorporates AST and platelets, and also the FIB4, which is a little bit more of a complex one, including age and ALT. But the idea is that perhaps this is a little bit more accurate and more sensitive than APRI. But again, this is something that we measure all the time in clinical practice. Now, when we look at their correlation with invasive hemodynamics, this is what we saw, that the patients that had high scores, so for FIB4 more than 1.45 and for APRI more than 0.5, those patients invariably had abnormal hemodynamics with exercise. However, when we focus on the ones that had better values or normal values, you can see the numbers were all over the place. And I think they really speak for how complex the pathophysiology of Fontan-associated liver disease is. But again, if they're abnormal, I think they're helpful because, again, chances are that the underlying hemodynamics are indeed abnormal. Now, but we're not hepatologists, right? So we're cardiologists. So why don't we talk about the stuff that we use in cardiology? And I think we can start with NT-proBNP. And surprisingly, although we measure this all the time, there's not a whole lot of data out there in Fontans to guide actually the use or the interpretation of those values. And when we looked at resting values, actually there was no correlation between NT-proBNP levels and Fontan pressures or NT-proBNP levels and wedge. However, with exercise, there was. And actually, these correlations are very similar to what we see in HFpEF, suggests that indeed we could use NT-proBNP to estimate invasive Fontan pressures. Now, what about peak VO2? And actually, we saw that peak VO2 was inversely related to resting Fontan pressures and resting wedge. And this also occurred during exercise. Again, this mirrors the data that we have from HFpEF, again, suggesting that Fontan patients and HFpEF patients share a lot of similarities. Now, when we saw that, we thought, what about incorporating the two to try to phenotype these individuals? And again, as we used a high BNP, so more than 300, or a low VO2, less than 50, and as we phenotype these patients, the ones that had abnormal values, so low VO2 and high BNP, had higher pressures than the ones that had a preserved VO2 and normal BNP levels. Again, suggests that we can use those two widely used metrics to predict their exercise hemodynamics. Now, but these are all surrogates, right? What about trying to do something a bit more direct, but still remaining non-invasive? I think this takes us to the idea of measuring peripheral IV pressures, and then this is Jamil's work that I think really changed the way we assess these patients in the outpatient setting or even in the hospital, since he showed that peripheral IV pressures, actually, they track very well with invasive measures. And we knew about that, and we were not doing this until we came back from Cincinnati, and we heard Alexander talking about his experience in Belgium. And after that, we started doing this routinely in our patients. And as you can see, just like Jamil, we saw that actually their correlation was pretty good at rest. But amazingly, actually, the correlation was better with exercise, and then they were only off by 1 or 2 points, suggesting that not only we can use peripheral IV pressures at rest, but we can also use them during exercise. So I think this takes us to the last summary, which is this idea of non-invasive surrogates for exercise Fontan pressures. And I think we can do that, but we need to take advantage of all the data we have. And that goes for spleen size, liver fibrosis scores, NT-proBNP, and peak VO2. But also don't forget that peripheral IV pressures are accurate at rest and then during exercise as well. So in summary, hopefully I convinced you that exercise catheterization is part of our toolbox in the assessment of Fontans in current practice. And the reason for that is because it can diagnose diastolic dysfunction, it can provide other reasons for exercise intolerance, and it can also give you incremental information regarding Fontan obstruction. But of course, not all patients need to come to the cath lab, and I think we're going to learn that more and more. But in order for us to do that, we have to use all the data we have. Don't forget that the liver and spleen, they actually mirror underlying hemodynamics. And then finally, just use your peripheral IV pressures if you really want to get accurate data both at rest and during exercise. And I think before we finish, I just want to go back to Greg Lewis's kind of drawing board. And then again, he suggested this holistic approach to the evaluation of exercise intolerance in acquired heart disease. And I think in order for us to understand and actually treat our Fontan patients, we really have to do the same and think about all these different components: the lungs, diaphragmatic function, cyanosis, the liver, the skeletal muscle, and of course their heart. And I think only having a holistic approach to this very complicated puzzle, we're going to be able to improve our patients' quality of life. And Rafa, with that, I'll stop here and I'll open up for questions. And again, thank you very much for having me here. It was truly a pleasure.
Thank you very much, Will, for an excellent talk. And excellent work. So I think that it's very exciting to have this new tool. So I have some questions in the chat. So one question from Rizwan from Saudi is what is the expected increase in SVC and PA pressure in Fontan patients that would you consider normal when you do exercise?
Yeah, that's a great question, Rafa. And I think I think the question is what's normal mathematically and what's normal. I think we saw that even in the individuals that are doing better, actually there's a lot of especially venous hypertension with exercise. And I think it explains, for example, the Fontan associated liver disease and some of these other dysfunctions, even in the patients that are doing well. I think for the venous pressure probably is going to be around 25, and for the wedge less than 20. If we look at the ones that had lower wedge to cardiac output values and less end organ dysfunction, we're actually working on this, trying to look at coming up with normative values. But so I think now I would say 25 for the vein and 20 for the wedge.
Oh, that's good to know. So Alex is here. So Alexander is asking, thank you for the fantastic talk, and his question is regarding the stenting in the conduit. Have you had any issues with the stents at the time of transplant? So one of the discussions that some people have now is just stenting everything if it looks small, but after when we go and transplant these patients and want to do the IVC anastomosis, the stent is on the way. So there's this discussion whether or not stenting the Fontans is going to be long-term beneficial if it's going to cause technical issues when you transplant the patients.
Mm-hmm. I think that's a great question. I think we don't know. I'm trying to remember now. I think we had 2 patients that were transplanted after prior stenting, and I don't recall them being an issue. But I think perhaps the overarching question is, are we achieving anything with these? I think that's the first step. I mean, it does look better, but are we achieving anything? And we actually just looked at our data, and hopefully we'll be able to submit this. And we didn't see much of a change. We saw improvement in exercise capacity, but in terms of other markers, we didn't achieve much. Now we can argue that probably we're intervening too late, and then by the time there's overt liver disease and overt thrombocytopenia, I think we missed the boat. But I do think that we need more clinical success on top of angiographic success to know what we're actually doing with these stents. I mean, I know that this is a very controversial, and people are very passionate about making the Fontan pathway larger, but I think we need some clinical data.
I totally agree with that. I think it's great that we are measuring things now, understanding the physiology, which I think is where we are. My question is regarding this point is should we be doing this in patients that are asymptomatic at baseline when they are transferred to us and see where we are? Mm-hmm. And not wait until the patients are symptomatic and then there is no much we can offer, apart from the one that has limited peripheral oxygen extraction, where exercise seems to work in these patients. In the other patients, this is a question that I have. If I have a patient that has a small conduit with 18, I'm able to identify that with 18 when there is not yet enough or significant liver dysfunction, for example. If I stent that patient by them, will I change the outcome of that patient? I don't know. This is a completely philosophical question. I understand.
And I think that That's a great point. I think we've talked about this, that again, some groups have proposed that we should cath patients when they're doing well to identify things early. And I think this is the same principle. Maybe we should do things early to ensure that we're not sitting on something that is actually hemodynamically significant. So we have thought about that, and actually I think we might have changed our practice a little bit, trying to even identify patients that are otherwise doing well.
So I had another question on the chat from David, one of our fellows. Thank you for the amazing talk. I saw the lactate value in your tables during the invasive exercise, and his question is, how do you use the lactate in your exercise assessment?
Yeah, so this is something that we incorporated as we move forward with the learning curve. So we measure lactate in every patient undergoing exercise, and the issue is that lactate can become quite abnormal even in normal individuals as they pedal a lot. So in normal individuals, you expect lactate to rise. So I think in terms of outlining the underlying problem, I don't think we've identified that. I think one thing that the lactate does help is when you have very submaximal exercise. You can see some patients, they really reach a high Borg, for example, but the lactate is completely normal. So I think this really suggests that perhaps there's a lot of deconditioning, and the patient can even bring the lactate to an abnormal level before they become profoundly abnormal. So I think it gives us a sense of how much maximal exercise we're achieving here, instead of actually pointing towards whether there's the lung versus the heart versus the muscle. But we've been collecting data, and we plan on analyzing that as well.
Mm-hmm. It's another question from Dr. Ahmed saying that would exercise echo or exercise MRI be potentially helpful?
I think so, and I think this is actually the end goal. I think is try to correlate these invasive measures that we do and try to do them non-invasively, also because then you can do them serially. And I think this is what, if you think about the journey in biventricular circulation, we started doing these invasive cath studies, and then we understood how, for example, mitral inflow works. So I think in a perfect world, I think we can combine peripheral IV pressure with mitral inflow and stroke volume calculation, just like Alexander has been doing. And I think hopefully they'll be able to give us most of the information without having to bring them to the cath lab.
So since Alex is here, Alex, if I wonder if you would mind if I ask you a question. So do you exercise all your Fontan patients when they are asymptomatic, or do you exercise them only when you have to answer a question because they are symptomatic?
So what I've been doing lately now in clinic is incorporating the CP study that we're usually doing with exercise echo. So instead of just having a CP study in the patient, I have a CP study plus baseline and exercise echo plus the peripheral venous pressure measurement. So trying as many of our patients to have at least once that assessment, and then continuing the classical follow-up with CP studies.
I think that's the data that I think we need, because I think that's going to tell us what the patient is at the beginning, right? And we'll be very interested to know if you see a change, how that exercise test change and how that correlates with the symptoms of the patient. So I think that's very exciting data to have. So there's another comment here from Dr. Chifra that say the exercise stress echo with semi-supine bike and continuous image acquisition can give us some non-invasive data, which is exactly what Alex does in Leuven, and with the peripheral venous pressure as well. And I think that the results of these studies are very exciting. So Erwin, I guess that you have a question? Erwin, you are on mute, Erwin. Erwin, you're mute.
Thank you very much, Will. This was a very, very thoughtful and inspiring presentation and talk. The exercise testing in the cath lab is quite resource intensive. So how much time do you schedule to do an exercise test in a Fontan patient?
Mm-hmm. I'm glad you asked that, because I was thinking about this morning. So I think we're a bit spoiled here because of all the work that Nish and Barry Borlaug did. So I think the cath lab staff was very used to doing the exercise setup and the exercise studies in acquired heart disease. So I think that made our life a little bit easier as we try to exercise Fontans. Now I think now we're kind of down to, we can get, once the sheath is in, we can get the exercise done and we can get the angiography done within an hour. So I think, so it's not as disruptive to the schedule. Now I think it does require some attention to some detail. So we always do them first because of the issues with, of course, being MPO, and then of course the issues with dehydration in Fontan. So we always schedule for first case in the morning, and that limits the number of cases that we can do a day. So typically we can't do more than one Fontan, which hasn't been that much of a problem. And again, I think it's just having the staff be comfortable in patients with congenital heart disease and patients that are cyanotic. So it did take some learning curve, but I think after we did about 20 or 30, I think we got kind of the system down, and we can do them without delaying things much. But there's no doubt it does take a lot of coordination, and it takes more techs in the room. So I don't think we can take this lightly in terms of what this means from a resource standpoint.
I have another question. How many patients have you exercised so far, and have you observed any serious complications during exercise in the cath lab?
So we've done 70.
Bleeding complication in the groin, when the patients are moving and cycling.
No, and I think and really kudos to Alexander when he put this idea forward. I think a lot of us thought this was actually a bit crazy, but then as we started doing it, actually it went very well. So we've done about 70 now. We haven't, knock on wood, we haven't had a single complication. The only patient that had something that was a bit eventful, if you will, was a patient with an AP Fontan that had paroxysmal atrial flutter, but she had paroxysmal atrial flutter in the outpatient setting and had flutter even before we got access. So so far we haven't seen any issues, but I think we've been very pragmatic about it. So I think fortunately we haven't seen issues with the exercise part. I think the other thing that I should mention, and this was also part of the learning curve, I think the counseling is very important. I think this idea of exercising during cath is I think is very foreign to providers, and of course is very foreign to patients. And also remember that most patients with a Fontan circulation had their caths during pediatric years, and a lot of them were done during GA. So I think the pre-cath counseling has been critical to make the procedural part actually smoother.
So I think that that is very exciting to have this data. But one question I have: you said that you have done 70 cases, right? How many of them have you repeated the exercise cath after you did an intervention and the patient improved? Any? It's just to see if my question is what we see clinically is correlated to what we see in the exercise.
Mm-hmm. Yeah, that's a great question. I think this is the focus of one of Alexander's current studies, a prospective one, where we're going to try to repeat the cardiac catheterization after intervention. What we have done is actually a patient having a repeat cath after stenting, and then we saw that after stenting, really there was no gradient. So it wasn't really to reassess the stent part, was because of clinical decline, but I think it was nice to see that, in one patient, the gradient went from 7 to 0 after exercise, but the clinical picture declined. So you can argue that probably wasn't success to begin with. But I think this is the next step, is trying to understand what we're doing and see if you're achieving something hemodynamically as we, for example, add sildenafil or you name it.
Mm-hmm. Okay, if anybody has any questions, I think that, well, yes, we are almost on 9 a.m. So I think that the work that you and Alexander are doing is fantastic, and I think that will bring a lot of new data on how to manage these patients and what to do with them when we are stuck and they are very sick and we don't have much data. So thank you very much for your excellent talk. Thank you again for joining us today, and to everyone that has joined, thank you for being here today, and we'll be here in a couple of weeks just before Christmas. So wherever you are in the morning, good afternoon, or good evening. Bye-bye. Bye, Will.
Thank you again. Yep.
Thank you, Will. Thank you very much.
No, you're welcome. It's been a